Okay.
Maybe you could move it to presentation view. It's a little bit to the right of where your mouse is. Yes.
Oh, okay. All right. Is that okay?
Yes, this is perfect.
Okay.
So we're ready when you are.
Okay, all right. I think, yeah, I can start.
Yes, ma'am, we could start.
Oh, okay, all right. Hello, my name is MUKUKA. I'll be presenting my research entitled Comparing the Performance of HIV Rapid Diagnostic Tests Used in Zambia, based on a systematic review of data from a clinical performance study. Despite the strategies put in place to end the HIV and AIDS pandemic, a substantial number of people with HIV are still unaware of their status, and this may be contributing to the spread of new infections. Globally, about 20% of HIV infections are due to transmissions from recently infected individuals. So 2 sequential rapid diagnostic tests are recommended for the diagnosis of HIV, but however, 3rd-generation RDTs, or rapid diagnostic tests, detect only HIV antibodies and so can miss up to 75% of early HIV infections. So Zambia HIV test algorithm uses RDTs that only detect antibodies and not antigens, and hence increasing the likelihood of reporting acute HIV infections as negative. This study aimed to investigate the performance of HIV RDTs used in Zambia. So the only way to determine a person's HIV status is to have an HIV test, and therefore these tests need to have the highest sensitivity and specificity. There is considerable interest in revising HIV testing guidelines to improve the specificity and sensitivity of the tests used by identifying challenges and include more accurate new testing technology. So most studies on HIV RDT kits report varying sensitivity and specificity with test specimen types. This shows the need to assess HIV RDT kits used in specific settings. Studies have shown that evaluation of accuracy of HIV testing strategies in high HIV prevalence countries still remains limited. The study employed quantitative methods by measuring statistical analysis of different variables of the 5 different HIV tests by using probability methods. So 2,564 participants aged between 15 and 95 years from 2 sites in Lusaka province were tested on OraQuick Advance, Abort Determine, and then confirmed on Unigod recombinant. The data from the participants were analyzed using SPSS version 25.0. So exact sensitivity, specificity, positive and negative predictive values were calculated according to the binomial distribution with significant level at 0.05, which is 95% confidence interval. Samples collected included oral mucosa transuded using the OraQuick HIV self-test kit, then finger prick tested on Determine HIV. If positive on Determine, it was then confirmed on Unigod. Then this test was done in accordance to the Zambian national testing algorithm. So in addition to these tests, 10 mils blood was collected in laboratory for more testing or to be tested on 4th-generation Abort HIV antibody and antigen as the gold standard for the rapid test. So these 3 rapid tests were compared to this 4th-generation Abort Architect HIV test. Key findings. This study raises the possibility of an 1 and 2 and Unigod, HIV, and also OraQuick Advance. These are the key findings from the study. This study raises the possibility of unacceptably low sensitivities of the RDTs that are being used in Zambia, which are Aller-determined HIV 1 and 2, and Unigod HIV, and also OraQuick Advanced Rapid Test. The results of this study have several important clinical and public health implications and treat strategies. There is a need to use and scale up highly sensitive and specific HIV RDTs to optimize the first and second steps in the HIV care cascade, which are diagnosis and linkage to care. The determined HIV 1 and 2 antigen antibody combo rapid test is one example of many other fourth generation tests that have been invented for the main purpose of detection of both antibodies and the antigen P24 at the point of care setting. The introduction of such a test to the HIV testing algorithm would significantly increase total positive tests being caught in early stages. So the results, these are the results from the study. So the 3 RDTs were compared to the 4th generation Abbott architect results and had the following results. So OraQuick Advanced, Aller-determined, and Unigod at 95% confidence interval had sensitivities of 91.8%, 93.3%, and 92.5% respectively. The specificity of OraQuick Advanced and Unigod were the same at 100% and 95% confidence interval, but slightly different from Aller-determined, which had 99.8%. The positive predictive values at 95% confidence interval were 100% for OraQuick Advanced and Unigod and 98.4% for Aller-determined. Negative predictive values at 95% confidence interval were 99.1, 99.2, and 99.1 for OraQuick Advanced, Aller-determined, and Unigod Ultra respectively. The results showed that the positive results. This is the table, the result table that shows what I'm just from explaining. So OraQuick, Unigod, and Determine were compared to Abbott Architect, which was the standard or the gold standard. And these are the number of total positives that were obtained from each test compared to the Abbott. And then we have the negative results, total negative results. Then the false negatives, false positives, the sensitivity, specificity, positive predictive value, and the negative predictive value, as explained. In conclusion, 3rd generation RDTs are not effective in detecting acute positive cases. 4th generation rapid tests are required to capture the positive cases being missed out. An alternative HIV testing algorithm, which includes a 4th generation determined HIV 1 and 2 antigen antibody combo rapid test with a better sensitivity and specificity is necessary. Developing and introducing a point of care test with adequate sensitivity and specificity for acute HIV detection is extremely challenging, but very feasible. In a resource limited or point of care setting, rapid diagnostic tests that aim to simultaneously detect HIV antibodies and the P24 can pose important alternatives to screen for early infections. Thank you.